We are back with video 2 of chapter 22. Next, we're covering tuberculosis, which is a huge problem worldwide. In the United States, there's around 9 million cases, and you may know that there's 350 million plus people in the United States. Compare that to the rest of the world where a third of the population is infected. 1 out of every 3 people is infected. 4 people die every minute worldwide due to this infection. Just think about that for a second. The tremendous scale of the devastation of this infection. This is a slow progression type of infection. Death doesn't come quickly after exposure. This infection is killing a lot of people, and it's not getting the same kind of attention as other less devastating infections or conditions. Why is that? We really should turn more of our attention and spend more research dollars trying to bring this infection under control. It's an important health issue that has implications here because the antibiotic-resistant strains get introduced here and they're very difficult to treat. There are really multiple forms of tuberculosis. Primary infection, primary tuberculosis, is that initial case. Your body will attempt to wall it off. Our system often does a good job of keeping the infection very localized and contained, but it doesn't kill it off. The organism survives within this structure of containment. Secondary tuberculosis is when the infection breaks out of that containment zone and starts to reestablish itself. If your body can't get that contained, then the infection will disseminate into multiple systems and throughout your body. This is the most serious infection capable of causing the fatal outcome. So how do you diagnose tuberculosis? Well, you may have had tuberculosis skin test at some point. If you remember, that's one of those class 4 delayed type hypersensitivity reactions. If you've been exposed to TB, your immune system, specifically the T cells, are on high alert for this particular pathogen. Exposure to the antigen in the tuberculin skin test causes a localized reaction that's visible and allows for the positive designation of the test. If you aren't able to use a tuberculin test because you were vaccinated with BCG and thus would react to the antigen in that test, then you possibly would use X-rays. BCG is a vaccine strain of Mycobacterium that they use in other countries. In the United States, we do not vaccinate with BCG, but if you're vaccinated elsewhere, you definitely will react to the tuberculin skin test. You would have to use some other mechanism to diagnose tuberculosis and determine if the person's actually sick. In addition to the X-ray, they would be looking for acid-fast bacteria in the sputum sample. There are some multiple drug-resistant strains of Mycobacterium tuberculosis that are resistant to a lot of different antimicrobials. They're very concerning and they are very difficult to treat. Mycobacterium is a slow-growing bacteria, and it usually takes 18 months of antimicrobials for them to be eliminated completely. Patients do not always complete the regimen because it's so lengthy, and they are not without side effects. So once people feel better, they stop the antimicrobial treatment, but they have not killed all the bacteria in the system. These slightly resistant forms are passed to new patients, and the process continues until there are very resistant forms. These highly resistant forms are spreading and are really difficult to treat because the cocktail of drugs needed are not always effective, and they may have even more severe side effects. Here's a diagram of how this infection would progress if the organism is inhaled into the alveoli. Macrophages would then ingest the organism. They ingest it, but they're actually not able to kill the organism. Thus, the organism will multiply within the macrophage. So as the macrophage is trying to kill off the organism is multiplying and dividing. Macrophages fail in their attempt to kill. Then you're going to see localized spread of that particular infection, but then your body will eventually call in the troops, and this particular structure, seen here, is a whole bunch of activated macrophages surrounding the population of mycobacteria to try to keep the infection contained. This is called a tubercle. The inside of the tubercle will degrade. There are dead macrophage components and dead tissue cell components and bacteria inside. The process is referred to as casus necrosis. It still has living mycobacterium within it. If your immune system is suppressed a bit, then the organism can escape and from that structure, and that's secondary infection. If that escape and spread is occurring on a more widespread scale in the system, then it's a disseminated infection. Remember, this infection is widespread on a worldwide scale, and it's not non-existent here in the US. We need to be vigilant and we need to spend more effort trying to address this infection worldwide, because infected individuals will continually be coming to the United States and potentially be sources of outbreaks. The next bacterial disease is called pertussis, or what is otherwise known as whooping cough. The organism that causes this infection is a gram-negative bacillus named Bordetella pertussis. This bacterium makes quite a few toxins, but a key toxin stops the movement of cilia in the respiratory tract. This leads to a lot of the symptoms that are associated with the disease. The organism is seen attached here to respiratory epithelium, and the cilia are visible around it. This is pretty important infection in the United States. We have still had some periodic problematic outbreaks despite the availability of a vaccine. There's still quite a few cases. There were 42,000 cases in 2012, a particularly bad year here in the United States, despite the fact that we have the DTaP vaccine. The P is for the pertussis component of the vaccine, which is whooping cough. This is due to the fact that we have people that are refusing to vaccinate or later refusing to get a booster shot, and thus we have outbreaks of this infection. This infection is most deadly in infants and very young children. If you're older, then the infection might be experienced as a very terrible cold with a lot of coughing. The coughing fits can last for quite a long time. You can have 2 to 4 weeks of coughing and up to 40 or 50 fits a day. In infants, these coughing fits can actually be deadly. It's a very contagious disease. If an adult acquires the infection but is experiencing it as a terrible cold and then passes it on to an infant that hasn't had the chance to be vaccinated and develop immunity yet, this can be life-threatening. After the incubation period, which is between 6 and 20 days, then you have that beginning phase which it feels more like a cold with some coughing. This is known as the catarrhal phase of infection. The fits may develop during this phase, but then the patient enters the paroxysmal phase, which is the characteristic phase of the infection. That's where these coughing fits occur up to 50 times a day, and it can last a few weeks. These fits are not like a normal coughing fit. You continue to cough until you have completely exhausted your air supply, and then you inhale very rapidly. That gives the characteristic whoop sound of the cough. These fits are so intense that you can actually vomit. You can break ribs from coughing. You can pass out. This is not a normal coughing fit. This is a very serious coughing fit. You may have up to 50 a day. It's exhausting and dangerous, especially for infants. Let me see if I can move into this YouTube video quickly and play this, but if I can't, the link is here so you can find it yourself, or you can search YouTube for whooping coughs. There are several. Let me stop.
Kind of heavy. Uh-oh. There we go. Okay. It's okay. Okay, take a breath in, honey. Come on. Almost there. There we go. Oh.
Well, it's really hard to listen to that little child suffering from that whooping cough, but I did want to have you hear what the cough sounded like. If it didn't come out very good, then please find it and listen to it. If you recover, then you're going to move into the convalescent phase, and the fits lessen and begin to feel better. Here we can see that we have some spikes of whooping cough. These outbreaks tend to occur in pockets of the community. You can see the incidence. Here we can see whooping cough occurs far more frequently in children that are less than 1, right? They haven't had the chance to really develop full immunity to this vaccine. If somebody is infected and comes in contact with an infant, there's a chance of infecting these infants with a potentially deadly infection. Older individuals may experience whooping cough as a much more mild infection, especially if they've been immunized once, but then their immunity waned over time, maybe didn't get a booster. At least there'll be some level of protection. This next infection is one that is familiar to many, and you may have even experienced this infection yourself during your lifetime. Influenza virus is the cause of the true flu, and it is an interesting virus. There's a couple of different types of influenza viruses that fall under the general categorization of influenza type A and type B. These viruses have virulence factors that are on the surface of the envelope. One of the factors is a protein involved in attachment, hemagglutinin. Neuraminidase, as the name suggests, is an enzyme that helps spread through the mucus secretions of the respiratory tract. Hemagglutinin is interesting and actually causes red blood cells that come in contact with the virus to agglutinate or clump together. That's where the protein got its name, but its true function is to allow the virus to attach to the respiratory epithelial cells. One of the interesting characteristics of this virus is that it has a segmented genome. So, if an individual is infected with this virus and happens to get infected with another influenza virus at the same time, this individual might produce a hybrid version of influenza. You can actually get a new virus strain emerge from the individual because you get recombination of the segments into a new influenza virus. That's a combination of the two previous viruses that infected the individual at that same time. Those recombination events, where you have segments from two viruses combining into a new type of influenza, leads to a dramatic change in the proteins, which are the antigens recognized by the immune system. These recombination events are called antigenic shift. Antigenic shifts have led to the great pandemics with influenza. This type of event was actually what many expected to be the next viral pandemic. It still may lead to a new pandemic because it's happened several times in the past. The worst influenza pandemic on record was back in 1918-19 during the World War I. During this period, half of the world, imagine that, half, got infected with the flu strain that was circulating that year. The infection caused far more deaths, about 40 million, more deaths than the war did. It was devastating. The virus that caused that event is still subject of research to try to understand why it was so lethal. Obviously, prior to the COVID-19 pandemic, they already knew that the influenza virus had the potential for causing pandemics. Researchers and various individuals educated in public health and epidemiology had warned governments to get more prepared for such an event. It really did not occur as hoped, obviously. There is a vaccine for influenza, but we need a new one each year. This is because the virus had several strains circulating, and each can undergo mutations faster than other viruses to alter the surface antigens in a process called antigenic drift. What has to happen to have an effective vaccine each year is that the WHO and the CDC and other health agencies around the world monitor which strains are circulating and causing infections. The new strains of infections tend to emerge first in parts of China and Asia and then move across the globe in a somewhat predictable pattern. Epidemiologists here in the US have the benefit of having the ability to monitor which new strains are emerging so they can adjust the vaccine to contain those strains and start to distribute it to our population before the strains really begin to circulate widely here. By beginning the vaccination in the months leading up to our normal flu season, usually we can avoid large-scale epidemics within our population. The vaccine is not 100% effective for a couple reasons. First, they don't always get it right. Sometimes the flu strains that are commonly circulating in the United States are not the flu strains that they had developed the vaccine for. So then, we end up seeing more influenza even with good vaccine distribution among vulnerable populations. Also, the virus does keep mutating, Antigenic drift is occurring, so at times the vaccine is not as effective as it might have been. If the strain mutated in a significant way such that the antibodies to the vaccine strain are not as effective against the variant, an individual may have been vaccinated but still get infected and sick. Remember that this infection does kill a significant number of people each year in the United States, so getting the flu should be taken seriously. If you're in healthcare, you need to keep your vaccinations current each year because not only are you protecting yourself, you're protecting your patients. There are some drugs available to treat this viral infection, but they have limited success. They have almost no efficacy if given later in the infection. They have some success if given early. This slide has a figure from your book that is showing the difference between antigenic drift and antigenic shift. Might be useful to take a look at it. We can't leave the respiratory virus section without saying something about COVID-19. I'm sure you remember now that it's an RNA virus. It has a genome of RNA. The RNA genome is a single segment. It does mutate. We have seen variants, but it does not mutate as quickly as influenza does. A person that gets infected with the SARS-CoV-2 virus, the agent of COVID-19, has the virus attached to the ACE2, the angiotensin converting enzyme 2 receptor that's present on the lung epithelium. That receptor is not limited to the lung epithelium. We know that the receptor is also on the endothelium of your circulatory system and other cells. We know that for some individuals, the infection is asymptomatic or very mild, more like a cold or a bad cold. For some patients, it's going to cause a much more severe infection. There's a COVID pneumonia that can progress to what's called the acute respiratory distress syndrome, or ARDS. During ARDS, the individual's lungs filled up with fluid and the patient is basically drowning, is starving for oxygen. The oxygen level in their blood can dip quite low. Other problems such as sepsis and long-lasting lung damage are possible, as well as superinfections and longer-term suppression of the immunity that leads to secondary opportunistic infections. They have discovered that the virus has the ability to interfere with interferon cell signaling. This effect allows for more viral spread through the infected individual's body. In addition, they've documented what's called cytokine storms in individuals that are experiencing serious infection with the virus. Cytokine storms are an overreaction of your inflammatory response. Basically, the individual experiencing the infection is overstimulating the immune response as it relates to inflammation, and that leads to widespread tissue damage, and it definitely relates to the acute respiratory distress syndrome. Many details of the effects of this virus are still being worked out, and there's much research underway to understand the details of how this virus is affecting our bodies. For this last disease, we'll be talking about an interesting mycosis of the lower respiratory system. Mycosis, if you might recall, is the term for fungal infections. Valley fever is so named because it was discovered in a cluster of cases in the Central Valley, California, where it's endemic. It resembles a pneumonia. Sometimes it's confused with tuberculosis. The diagnosis is made by seeing these little sphericles in the tissues. Valley fever is endemic in the southwestern United States and in Mexico. It tends to occur in drier areas. It's caused by the organism Coccidioides immitis. This organism is dimorphic. It's one of those fungi that becomes a yeast once it's in the human body, once it has plenty of nutrients and is in the human body temperature, but it's a mold or a spore in the environment. It's acquired, surprise, by the respiratory route. The spores are found in soil, so when there's wind or something that stirs up the soil, infections tend to rise in the affected locales. It begins in the lungs after inhalation, but it goes systemic. You can see these lesions can occur all over the body. About 3% of the population in the Central Valley of California gets infected every single year. Not all of these people are elderly or immunocompromised. Healthy, younger individuals do get infected, but typically these tend to be mild and they're resolved on their own. If the infection is more serious, fungal infections in general take a longer time to treat, so the course of treatment will be over weeks or months. Since this infection is endemic to California and the Southwest regions, you probably will come across it if you work with patients in healthcare. So, okay, we're done with the infections we're going to cover in Chapter 22. See you in the next one. Hang in there, everyone.